So first of all, good morning to all of you. It's a pleasure to be today speaking with you. I believe that it will be more a conversation than a keynote. So feel free to engage during the presentation. I will share my slides with you. So I will talk about healthcare innovation. This is from the ones that are not Portuguese. This is a picture from Azores, beautiful islands in the middle of the Atlantic, where we can, at least we don't have the notion where are we going, but there is a path that we need to trail. So I believe that this idea about healthcare innovation is there, and I will just try to speak a little bit about it during this half an hour. So I'm a healthcare manager, as João was saying. I work in a hospital center. It is a very, very huge hospital. Nowadays, of course, we are under some stress due to the COVID. But actually, it is a very, very. It's the biggest hospital in Portugal regarding hospital beds and healthcare professionals, and it's located in the city of Coimbra. So I will talk a little bit about the healthcare system. Why do I think we need the innovation? What are the innovation barriers? And then I believe that we will have also some time to discuss the need to redefine the role of hospitals and to discuss a little bit among us. So the healthcare system, I will share some data also from Portugal, but I believe that most of it's applied to other countries. But actually, I believe that we have done a very, very good work since these new health systems that we developed after the Second World War. Mostly this idea of universal health care, access to universal access to care, and most of the high-income countries, we have done quite a lot, and you can see here, for example, regarding the life expectancy, or years of life gain, and almost on this OECD countries, so high income countries, we can see that we have done a great job, and this is a comparison between the 60s and the end of the first decade of this century, and we can see that we have done a lot in high income countries, mostly due to this idea of an organization of healthcare that, as I was saying, it believes on universal access to care. In most of these countries, we have a very, very high percentage of persons that have access to care, at least in a theoretical point of view. And also, we develop a system mostly based on these levels of care, where we can distinguish different silos, and that can be a problem, and I will discuss a little bit about it. Mostly developing on primary care, secondary care, and tertiary care. This was the model that was developed. Most of it is a hospital-centric model, but this model has allowed us, for example, this is data from my country, reducing infant mortality for something that we have never seen. And this is quite relevant for high-income countries. And when we compare this with low-income countries, we will see that is a completely different picture from what we see in high-income countries. So all this paraphernalia, all this differentiated care allow us really to achieve very, very relevant and unimaginable healthcare outcomes during the last 50 years. Even here, just showing you some data in EU regarding life expectancy, the growth that we had since the beginning of the last century, it's something that no one would believe. So we mostly doubled our life expectancy in a few decades. Okay? So the system as plays rules, but, and there is always a but, the issue is that even in high-income countries, and I will focus in high-income countries, we continue to see persisting inequalities in access to quality of care. And we can see this in different between countries, even within Europe, but we can see also this within regions in the same country. So, and of course, differences regarding to income also are there. For example, I must say that, for example, in my country, in Portugal, there is a higher risk, 4 times fourfold higher risk of having diabetes in someone that didn't finish high school, when we are comparing it with persons that finished high school. 4 times. It's not something neglectable. So we can continue to see that even though we developed and the healthcare systems are quite developed, we continue to see these inequalities. Also, it's not new to anyone, and actually the course is focused on this, is that mostly the demographic changes are there, not only the demographics, but also the epidemiological changes. We came from 50 years old, our main concern in healthcare were infections. And so we develop acute care, and nowadays we focus on chronic disease. So we change regarding epidemiology a lot in the needs of the population, but also we know that the demographics has changed a lot, and we need to deal with increasing percentage of our population that is over 60, 65, 70 years old. Also, within this, and we can say these two main issues, we continue to have high fiscal constraints in most of the countries, and most of the discussion, even during the last 3 decades, and an healthcare manager across Europe, it has been to find ways to control costs, and actually we failed in all of them. And we also may say, and we must assume, that most of our strategies to control costs failed. And most, even after the last economic crisis in 2008, what we have done mostly is to try to control the prices of inputs. And actually, what we have seen in the last years is that the prices of the inputs, and when I say inputs, I say wages, salaries of healthcare professionals, or the prices of medicines, of medical devices, all those prices continue to grow, and they are not controlled at all. So most of our policies to try to control costs have failed also in the last 30 years. And at some point, governments start to try to control costs to reduce the amount of care that is provided or that is covered, or even to reduce the population that is covered. And you can see this, for example, in some countries where, for example, migrant populations don't have access to healthcare, or other populations that don't have insurance, they don't have access to healthcare. So all these strategies are defined to try to control costs, and I must say everyone have failed until now. So that's why I believe that we need, and it's mostly a rescue call for innovation, and how we are going to address this the issues about innovation. I always present this this slide. That is, as you can see, this is from actually this is not from Chile, it's from Honduras, but the slide is not correct. When I will share this with you, I will correct it. But most of it, the slides, you can see that there is a bridge that I believe that we can imagine that is the healthcare system that we have right now, and the needs of the population is the river. And actually, the needs of the population are not or change their course. Okay? And most of the system continues to be as it is. And actually, until now, we didn't manage to move all this heavy system that we developed after the post-World War to face the needs of the population. And in that sense, I really believe that innovation can help us on changing the way that we provide care, and mostly all this machinery that we have right now that is probably immovable, and we need really to try to have a more flexible providers, more flexible institutions to address the needs of the population. So this is not new for you. The issues about aging, we changed a lot since the last decades. In the graphic, this is some data from Portugal, from a study that I developed only for inpatient care data. You can see that mostly the costs that we have when we hospitalize patients, and you can see on the graphic that first we have high costs, of course, on deliveries, and then after 50 years old, we start to grow a lot our healthcare expenditure. So mostly due to the need to hospitalize patients after 50 years old. When I could show you a graphic also with medicines expenditure per capita according to age, and we would see also the same trend. Just a curiosity and just to try to engage with you, you see that the blue line is men, and well, I tried to be red line is women. Do you know why you have this trend here between the 20 years old and the 49 years old, where women have higher expenditure per capita?
Could it be because of the birth rate?
Yeah. That's it. Yeah. That's it. You know that when I'm teaching, I always show this graphic and another one about medicines, as I was saying. And actually, as you can see here, the expenditure on women on hospitalization is lower than men. Do you have an explanation for this? Probably women are less hypochondriac than men. No, probably that's. That's but actually in medicines it's opposite. Probably there is some reason, I don't know, that is a study on it, that there is some reasoning about the expenditure per capita in women and men. Probably when you take more medicines, there is a lower hospitalization rates. But anyway, within this thought, we also see that even though we increase our life expectancy, actually our healthy life years is not equal across Europe. So you can see, for example, that in Sweden, after 65 years old, we have 16 healthy life years, when, for example, in Slovakia, we have 4 healthy life years. So in this sense, even though in high-income countries we increased a lot our life expectancy, well, in not all countries we live quite well. So mostly we live with disease, and that's not a very good thing, and that's another issue that we need to address. And this is data from Portugal. This is equivalent to other countries. Is actually the epidemiologic, mostly the proportional mortality according to disease groups. And you can see that, as I was saying previously, we change from infectious diseases And you can see here that there is a very low percentage of death per infectious diseases, and we move completely here for cardiovascular diseases and cancers and chronic respiratory diseases, but mostly cardiovascular diseases and cancers. And I must say that cancers is gaining some field to cardiovascular diseases, and I believe in the next few years, cancer will be the main cause of death. But anyway, what I would like to stress is that 86%, this is data from Portugal, but as I was saying, is equal for most of the countries. 86% of deaths are due to non-communicable diseases. So this has changed a lot, and the way that we need to address healthcare, or the way that we need to provide care, is quite different. And it's not only one disease, the problem, it's multimorbidity. And this is also data from Portugal. 41% of the population has more than one chronic disease. Okay? So, and actually, in this study that we do, only 41% of the population doesn't have one chronic disease. So this is quite striking. This is for adults. This is not for over 65. This is for adults, and actually, this is a main concern for all of us. Just to give you an idea, I believe this slide is better. And this is quite interesting when we discuss the way that we provide care and the resources that we have available. And in the left, you have the prevalence in primary care in a study that I've done for several diseases. So mostly when the family doctor diagnosed the patient, and you can see, for example, in the patient's list, almost 20% of the patients have high blood pressure. 7% depression, 6% there is diabetes type 2, it's not type 1, 0.7% diabetes type 1. But if you see the percentage of pharmaceutical expenditure, you can see that high blood pressure patients have 63% of pharmaceutical expenditure, and the diabetic ones have 44%. So, and depression 40%, almost 15%. So when we talk also about chronic diseases, we need to know that there is some concentration of expenditure in some diseases. Of course, some of these patients have more than, for example, someone with diabetes has also high blood pressure, and they are in both groups here. Another issue that I believe that is quite important when we discuss even this need for innovation is that actually, as we have seen for healthy life years over 65, we can also see different approaches on avoidable hospitalization. And this is a very relevant issue. In that sense, Portugal is placed quite well. This is also data from OECD. And actually, you can see that countries have different results when we discuss avoidable hospitalization, or we analyze avoidable hospitalization. Here, we only see this for 3 diseases: congestive heart failure, diabetes, and asthma. And we can see that some countries deal with the avoidable hospitalization differently. What we believe is that this is quite due also to the role of primary care initiatives and preventive measures, also screenings, and some specific programs to manage these 3 diseases. And I will talk a little bit about it afterwards. But this is quite striking. Even WHO has a very interesting program, and you can check online, and even I can share with you some studies in different countries that we analyze, mostly ambulatory sensitive conditions, where we can and we analyze very profoundly what are the hospitalizations that actually we could avoid and how we could avoid them. Okay, and actually what we see is that we continue to hospitalize. And most of these hospitalizations, of course, some of them are needed, but some of them are not needed, and some of them can be avoidable by interventions in ambulatory settings. Regarding hospitalization, this is also a study that has been done in our hospital and other 4 hospitals in the region. We applied a geriatric institutional assessment profile. It's a questionnaire that is used in other countries. But what we try to see is just inquiring our nursing staff what would be what they think about treating or caring about old the elderly population. And what we find out is that the perception of nurses is quite negative, okay? And they assume several negative points regarding this. And mostly what they say is that they are not prepared. The hospital is not prepared to treat the geriatric population. And this is also quite striking when we know that most of our hospitalized population is over 65 years old. Let me just share with you. I'm sorry, some data is in Portuguese. Data that I will publish in some I believe 1 or 2 months. But let me just show you some data that I've been working on what we call in English. I don't like the expression that is bed blocking. I don't know if you know what is bed blockers. Or we can say postponed discharges. So our patients that continue to be hospitalized, but they don't need hospital care. So actually, what we tried to do in this study was to analyze what is the percentage of patients that are hospitalized that comply with this condition. So they don't need hospital care, they could be discharged, but we don't have any solution to those patients. Most of them, I must say, I will not share that data with you, but most of those patients were waiting for long-term care institutions. Some of them, there isn't any support from social services. Some of them, the family can't have or don't have the conditions to have them at home. But there are a very differentiated number of reasons where patients continue to be on the hospitals. What we try to do on this study is, of course, to try to analyze that data, but also to try to see the magnitude. In this sense, this is the data from 4 years, 2017 to 2020, and what we found out is that for the overall services, this is a cross-sectional survey that we do every year in a Monday in February. So we do this inquiry to hospitals to see how many patients are there. And what we found out is that for the overall 4 years, 6.3% of the patients hospitalized were in those conditions. So it's a very high number. I must say that in 2020, where we have more hospitals participating on the study, we did almost 10% of the patients, almost 1 in 10. We also tried to analyze what is the length of stay of those patients in the hospitals, and the median length of stay was 77 days. So it's quite long. It's not to stay there for 1 or 2 days, it's to stay there for 77 days. You can see this is almost 3 months, so it's a lot, okay? And actually we did the studies about the cost of this and all that, but I will not share. What I would like to share with you is something that I believe that is quite relevant when we discuss innovation. And I will discuss this afterwards, but just to give you this notion and the need to redefine the way that we provide care. In the graphic below, we have the hospitals organized by the number of beds. Okay, so we have a group of the hospitals that have less than 200 beds, acute beds. We have a second group with beds from 200 to 300, a fourth group 300 to 600 beds, and then hospitals above 600 beds. What we found out, and statistically relevant, is that the group of hospitals above 600 beds have higher length of stay. So what we found out also, and this is not only due to the complexity of care that they are providing, what is due probably, and what we believe, is that these hospitals, and you have some data also for about hospital efficiency for these kind of hospitals, is that they are quite inefficient to deal with this kind of patients. Okay, and so this is quite relevant when we design the way that we provide care. So these hospitals, and when you compare it with smaller hospitals, you can see, and it also statistically relevant, is that actually they have better results. And this is quite relevant when we design healthcare, and we can discuss this a little bit later. And most of it is due to the work that those smaller hospitals have in the community, and the way that they engage with the community and with other levels of care. Just to give, this is also what we have done is some panel data behind it, and what we would like also this is a panel data regression. What I would like also to show you is that what we found regarding the percentage of hospitalizations is that the most significant, or the only significant findings that we had is the number, and we compare hospitals per region. It was the number of long-term facilities in the region, and that is quite proven with this panel data regression. And also this is another regression data. What we had is that actually, if you have a population over 80 years old, also we have an influence of the number of hospital in the length of stay. Okay, so we have here data that show us that actually, if you have patients with within the population, the percentage of the population is over 80 years old, you can there will be higher lengths of stay. So continue on this. I don't know if you have any doubts on this. This is probably too many numbers. Just to try to keep you awake. No, well, no questions.
I have a comment / question. Yeah. So I was working in a hospital in Mexico before coming here, and I took part in a small health management project. And what they were doing is that they were checking the record of each patient, but we needed to go through to the record and check if they were following the guidelines, the clinical practice guidelines. So now that the records are becoming electronic, do you think it's possible to correlate this like longer stay to following guidelines? And you can give like a number saying like, okay, this hospital is not following guidelines. So is this possible now? Is this something that people want to do, or it's not necessary?
Yes, since the 80s, there are lots of studies, what we call appropriation of the hospitalizations, and there are a lot of studies that have been going to medical records to try to see if the hospitalizations are adequate or not. I really believe with the digitalization of medical records, it will be possible to have better data and actually probably even live data on this. Even though this is a very time-consuming process, I believe, of course, with digitalization, it will be easier to do it. But what we need to try, I will not engage on this in the issues about during this talk, why do we hospitalize too much? Because there are several reasons for it. What I would like to stress out is that we really need to find ways of not hospitalizing. Okay. And in that sense, the way that and in that sense, innovation will play a major role. Okay. and the way that we develop innovation in healthcare will play a major role. Let me just continue, and we will discuss that a little bit later. Another problem about the system is that actually it's quite volume based. Okay, so actually even most of the systems are based, even they are financed based on the inputs that they put in place on the system, and actually they also finance by the number of outputs. And you can see, for example, countries where you have high number of procedures when compared with others, surgeries, MRIs, CT scans. Most of this is due to the way that we pay. Okay, so you see the United States, for example, in number of auxiliary exams, in MRIs or CT scans. You can see, for example, regarding hospitalization, Germany and Austria, that say for sure they are over-hospitalizing. You can see this in the number of procedures, even that they are not already at the moment recommended as the selectomies, the variation between regions regarding, for example, knee replacements or hip replacements. So most of this difference is, or at least some of those differences can be explained by the way that we pay. But what we know is that when we pay providers by outputs, we are increasing the volume. We are not creating value in healthcare. And actually, if you see the health, or you check health outcomes between populations, high provision of healthcare and low provision of healthcare is not clear when we in the regions where we over provide that we have better health outcomes. And in that sense, what we are mostly incentivizing is volume, and that is something that we are not creating health, we are creating volume. And in that sense, what I believe is that at some point the system will not be able to work adequately anymore. Okay, so what I believe is that this framework of input output will have this final end, that is the caput. Also, another point, actually this is a point that we are discussing in EIT Health. There is a high value care council advisory board now. You can check it online on the EIT Health platform. That this is a major strategic point for EIT Health, okay? The high value care. Another point is that actually we have some conflict in the notion what are corporate hospitals and the need to have profit and volume, and what will be the role of an hospital that is mostly concerned with the health of a specific population, what we call population health. Okay, so in that sense, there is some conflict between this idea of hospital efficiency and profit, and the need of dealing with the needs of a population, and that's also some problematic issues that we face by now. And if you see even the proportion of hospitals that are in risk of defaulting financial commitments across Europe, it's quite huge. And I believe that even in the COVID crisis, it will increase. Okay, so there is a lot also of financial pressure of hospitals and these financial restrictions that hospitals face. The bottom up, in my point of view, is that the healthcare delivery model is quite obsolete. Most of the care, the model is unplanned, not documented, nor managed. It prevails what we call, it prevails most of its flexibility, but we can say that even the public opinion see the system as mostly as unreliable and unsafe and prone to error. And as I have been showing, there is inexplicable variations among regions, among countries. And in that sense, the system is very, what I would say, obsolete. Also, and I believe that in that sense, innovation will play a major role, is that most of the system is still based on costume practice, precedents, and not on knowledge. What do I mean with this is that most what we do is not based in evidence, is based in what we have done previously. Okay. There is a study from the New England Journal of Medicine that says that only 1/3 of the medical practice is based on evidence. So 2/3 are just the way that you are used to do. Okay. So that is not bad, but when we say that this is a very high-tech field, we imagine that this is a very, very technological industry that is based on knowledge. But still, at this point, we don't give the credit, we don't have the data that allow us to change the way that we provide care. Okay? So in this sense, there is a huge road ahead on the area of dealing with data, and from data to transform those data in knowledge. So that's why I believe that we need this healthcare reform. And we have been discussing this for the last, at least I'm not so old. I'm working professionally for the last 20 years. But since the beginning of my career, we discuss healthcare reform. And in some sense, what we believe is that we need to move from the conventional care, okay, from this idea of selective primary health care, vertical organization, management of production and the quality of inputs. And we have moved to an idea of disease-oriented, and we, during the 90s mostly, we developed disease management programs, the linkage between levels of care, the management of the resources, and we try to focus on the quality of outputs. Then we moved to coordinated services, care management, horizontal provision of care, management of performance, quality of processes. But what we need really, and we need to move, is to an idea of integrated services. Okay, when we see the whole individual as a whole person, we have collaborative approaches. We are focused on the management of outcomes and on the quality of outcomes. And in some sense, still in 2020, we continue to be in conventional care. And we even didn't the pathway to disease-oriented coordinated services and integrated services. And when I say integrated services, just back to the discussion that I was giving you previously, we are not talking about only healthcare, but we are talking about social care, the role of municipalities, the role of community organizations in providing those integrated services. We are not only talking about integrated hospitals with primary care or with long-term care. What we are talking about is to try to find ways of providing services to the individual, so what we call patient-centered services. They are countries that evolve more than others, that are regions that evolve more than others. We have experiences in some countries and some regions and some municipalities that evolved a lot. But still, I must say that in several areas, we continue to be on conventional care. And this road is something that we need to walk. But I really believe that innovation will help us on developing those integrated services. Okay. And most of, I believe that the focus, and when we are talking about innovation integrator of services, is there. Because the conventional providers, they will not change the way that we provide care. We need innovation, new ideas that will engage and will force the change of conventional providers. So what are the entry points for those transformations? So people is the center. We need to work on the model of care, on the organization, on the management, in this idea of improvement. Technologies, governance, information, financing, the workforce and medicines will play major roles. And actually, I really believe that this input from technologies and from information, I will not talk about the other areas, will have a major role to change the way that we provide care and to help us on developing this idea of integrated services. So I must say that we are counting on you to develop those technologies and those process of innovation and the health instruments. If not, and if we are not able to do it, we will continue to have this poor coordination between different levels of care, and we will continue to have a failure to share information, duplication of efforts, errors, delays, and afterwards poor quality of care. Okay. I don't know if you have some questions on this. If not, I will go to the innovation barriers. Why aren't we able to promote innovation in healthcare? You are quite quiet. Are they like that as well? No, you are muted. Sorry.
No, I was saying that no, they are participative, but probably they are trying to digest the new concepts that you are exposing, which for some of them might be a bit far, but they are all of them working in biomedicine, and some are in healthcare so it's the challenge that they face. So there is a question from Karin.
Yeah. Can you say it? I have the screen share. I don't see.
So Karen actually asked if their integration for intervention strategy in proposed modes, is there integration for intervention strategies in proposed modes? This is the question. So
sorry, bad typing.
Bad typing.
It's really, I'm just trying to reconcile your role for integration strategies in these hospital settings. Is there budgetary reserve for them? I mean, are these being integrated at all? Planned for them?
No, what I believe is that, and even from my experience, and just give you an idea from my experience. For example, in our hospital, what we have, we started programs on remote monitoring of patients with COPD before we had a budget for it, before we have not a budget, being funded for it. What we need to do is also to work in payers, with payers, to and showing this is a very cost-efficient way of providing care. So we showed, and then we are now financed for it. And we are doing that, for example, for heart failure, for example, also. So what we need to do is to show that there are different ways of providing care, even though we are not funded for it, and then to convince the payers. For example, in COPD, we have demonstrated that we have reduced hospitalizations for COPD patients. And in that sense, we need to engage on this kind of innovation strategies, in new ways of providing care, and then convince the payer that that's cost efficient. So what I believe also is that, of course, university hospitals, they have a higher obligation than smaller hospitals. But what I show you in the data, in the previous data, that is not yet published, is that actually what we have found is that smaller hospitals have probably better engagements in the community than bigger hospitals. So actually they have lower budgets, but they have they are more flexible to engage in the community and to address issues like delaying discharges as with bed blockers. I don't know if I answered your question, Karen.
Yes, you did. Thanks. Thanks.
Let me just go to the innovation barriers. As you know, I don't know, have you ever tried to work with a hospital, for example, to with some ideas that you have, biotech, e-health? Have you ever tried to engage with hospitals to show them, oh, I have an idea, can we try this?
Yes, actually, I had a small experience about it.
And how it was? Was it positive?
I wouldn't say it wasn't. It was not negative, but it's quite complicated to enter in the world and to make like the bridge between the science and the problems that they have in the clinics. And it's quite difficult to involve all the people, from the nurses to the doctors, to involve all the people and to have really connected in the project, especially when they have a lot of work. And this was like a master thesis. So it was quite tricky. It was possible, but with a lot of effort.
Other experiences?
I have found that the sort of hierarchical chains can be quite limiting to people who want to get involved, like that they have to get permission or sign off, or, I think sometimes the limitations are just managerial or political.
Other experiences?
Yeah, I worked at a private hospital, so there was always another agenda. So whenever we wanted to do like compliance and management, it was more like a hotel. So I had this issue.
Okay. Well, if you don't have, if the others don't have any experiences, when you are going to try, or when you are trying to engage with an hospital or a major healthcare provider, not only hospitals, you'll see that the probability to have some resistance is quite high. Most of it, I always show this slide that is this idea about what most of the healthcare professionals are quite focused on their work. They are overwhelmed, and that's quite difficult to accept even good and very good ideas. Okay, and then we have all the complexity and the regulations on healthcare, and I will discuss a little bit afterwards. But it's quite difficult, and when we are discussing innovation in healthcare, when you are trying to develop ideas, solutions, products, we really need to know that is hard. Okay, what I believe is that from the healthcare providers to create some sort of fast tracks for innovation, it will be something. And I really believe in 5-10 years that will be much easier, because healthcare providers will see that the only way to become efficient and to provide good care, it will be accepting and testing technologies. Okay, not only technologies but also any solution. So this idea about all this resistance, we will continue to face it. But I believe at least in some institutions we are going to see those fast tracks, and you can see this in several countries, in more developed healthcare systems. You can see that, for example, they have already incubators within the hospital settings. They have innovation departments. They have different strategies where startups or even the science students can engage with them and have opportunities. Even we have already hospitals and hospital groups, for example, that even have capital to invest on those solutions. Okay, and we already have that, for example, in Israel, where they have capital investment for this. Okay, So even we have different, of course, approaches from countries and healthcare groups, but we will see this this trend. I believe that will grow. Anyway, as you are the first comers, you are going to continue to see this resistance. Okay. As you are this early arrival to the system, I believe that in some years, I believe it will be easier. And actually, you are going to develop strategic partnerships with some hospital groups that will allow you to test your products more efficiently. But mostly the challenges that we face in healthcare, and this is from Christensen. I don't know if you know Christensen. He was probably he, at least the concept of disruptive innovation was developed by him. He died some months ago. I recommend to read. Yeah, he has very excellent books, but also some papers. This is from Health Affairs, and this work mostly it shows these 4 ideas why we are not moving as fast as you see in other industries. Okay, so mostly the first reason is fragmentation of care. So actually we see that there are several providers and that work in silos that don't communicate. So when we try to test technology, well, I was saying that we need integration of care, and we need to have social care, social services, hospitals, primary care, municipalities, community services working together. Yeah. If you have a solution to bring everyone on board, actually you are going to face a system where no one talks with each other. So you are not going to be able to test that technology. So you see that it continues to have this fragmentation of care. There are several solutions that I have seen that they are quite interesting. For example, in integration, social services and hospitals, that the issue is not the solution. The issue is that the way that we continue to provide care. The other problem is that we don't have a retail market. Okay. So if you have a solution, you are not going to sell it in the App Store, okay, in the Google Store. You need to sell it to providers, okay, or you need to sell it to the payers. And in that sense, you don't have a real market and a market where you have a competition to new solutions and products. So it's quite hard also to the lack of the retail market. Another issue are the regulatory barriers. Healthcare is something that is highly regulated. Even you have seen, for example, and we have these fast tracks now for the COVID vaccine, but we have regulatory barriers that when we compare with other industries, it's quite different. And those regulatory barriers are needed, of course, to assure that the products that we have in place, they comply with all the safety measures. But when we are trying to develop even medical devices, nowadays, we also need to have all those studies. For example, we are testing in our hospital medical devices under several programs, some of them from EIT Health. And those medical devices they need to face all the regulatory steps to be approved. Okay? So that's another issue. If you are placing your solutions and products as medical devices, you will face several regulatory barriers, and that is an high cost on it. There are some solutions, for example, that place their solutions not as a health product, but actually then you have a lower credibility on the market, and you can see that, for example, in apps. Okay, so if you are developing an app, if you are going to place it as an health solution, you will face regulatory barriers. If you are going to spread large to in App Store, probably you are not going to get the success that you need. Okay? And you have also some examples of it. And then there is the reimbursement issue. If the payer, I talk about, for example, the issue about remote monitoring of COPD patients. If the payer doesn't have lines to pay for that kind of services, probably you are not going to do it, and you are going to face barriers from the providers on it. Okay? So actually, and it's quite difficult for a startup to go to the health insurance or to go to the Ministry of Health or the institutional player to say, I have a great solution, please pay for this. Okay. So we have always this reimbursement issue. So these are the major four issues that you face in the healthcare system. And of course, this will be quite complex to or issues to fail. Okay. I will just move for this. I believe that we have some. I don't know my timing. I checked, João. That's it's 11.
Yes, now it's 11. So if you want to take some questions at the end, so yep. I believe you can take more 10 or 15 minutes, but it's because we need to close at 11:30 maximum.
Okay. No, my point on this is that we are going to face these innovation barriers. What I would like also to say is that the components for the development of the business model, it will always to be also focused, and I believe that there are several trainings on this. That is the profit formula. Okay, actually, you can see always when you have a solution, you need always to develop these business models. You need to take into account all the processes, the ways of working together to address recurrent tasks, training, development, manufacturing, budgeting, planning. You need to take into account the resources that you need and to create this value proposition. The value proposition mostly is what you see when you are pitching and when you need to pitch not only in this kind of controlled pitch that you see, and you have the possibility to engage, for example, in ITL for other situations. But when we need to pitch to providers, to payers, you really need to offer this value proposition. And it's what I see, and even belonging in some juries or in several programs, what we see is that there are probably, and most of the time we have good solutions, nice solutions, inventive solutions, but actually the researchers, the developers or the innovators, they didn't achieve to offer a value proposition. Okay, so when you face a payer, a provider, you always need to know that you need to sell your business model, your idea. You can have the best idea in the world, but you need to sell it. I know that as researchers is not something that you are used to, but I believe as researchers you always defend masters and PhD theses and dissertations. So you also sell your idea. You also present abstracts in congresses and oral presentations. So at the end, what you need to do when you have an idea and you are going to the market is to create this value proposition. What I believe is that in this sense, innovation will help us to redefine the role of hospitals. It will be a market that will be quite different from what it is today. What we see from these closed door hospitals, these huge buildings, will be quite different in some years, and I really believe that the transformation will not be made only by the hospitals. The transformation will be led by innovators that will change the way that we provide care. So if you have some questions.
Thank you, Alexandre. So this is really challenging, and I actually I have a question just to prepare the students while they are thinking on their own questions or prepare their own approaches. But Alexandre, your talk is quite provocative in terms of intellectually. But I am 100% with you because we face really a reality of, I would say, a model that is not really prepared for the big changes that actually we are seeing and we can forecast in society. So clearly that there is a problem there. But taking these in as a reality, so if we need to dramatically change the way we provide health care, so how do you see that the states will suddenly, how can we deal with the huge investments that have been made, for instance, in big hospitals that clearly are not adequate to the future models? So there is a balance. On one side, you have a need to change, but on the other side, you are somehow restricted by the investments that are on the ground. So how do you see this? And you are in the field, so obviously there are discussions along these lines.
Now, first of all, and this is always the way that I believe that we move, or society moves. It's we try to have a scientific consensus in the way that we need to move, or at least there is some dialectic discussion about the way that we need to move, and at some point, some ideas will be followed. Okay? I really think that's, and we have been discussing this for the last decades, but what I believe that the trends that you need to focus on services and not in institutions is something that is there. Mm-hmm. And it's mostly driven by the consumers. Actually, what we see is that consumers, when I say consumers, I see the population, the individual, they are more and more dissatisfied with the way that care is provided. They don't want a system where I need to wait for access to care. I have overcrowded emergency rooms. I don't have access to my physician. And people are seeing that even with the aging factor, that the system is not developed as it should be for them. And you can see, for example, with increasing, and we didn't discuss this, but for example, the way, if you compare different countries or regions where the way that we deal, for example, with dementia, there are countries that are not facing it at all, or that they are countries that, for example, already develop home services in early stages of dementia. Actually, what we see, the families, and if you compare the satisfaction between those two groups, we would see immediately that there is a dissatisfaction from the population with the systems that don't deal with it. The issue for me is that those persons that are not satisfied, they are going to say, why I'm investing and paying from my taxes or paying insurance to services that I don't like, or that they are not providing the care that I need. So that will be a major trend. So all the public opinion behind it, I believe that will push for this change. Even though, and I believe that I didn't disconsider that the resistance will continue to be there. Sure. But also what I show you is that smaller hospitals, for example, actually have data from this. Smaller hospitals are more, not smaller hospitals, but hospitals between 200 and 300 beds, they are more efficient. We know that big hospitals are the efficiency is very, very low. And actually, what the study that I'm working on is that what we try to do is actually dealing with something that is the delayed discharge. Bigger hospitals have more problems than smaller hospitals. So what we see is that we really need to find ways of developing alternative services, and even from the medical community, we have seen this. And even just give you some examples of the changes that we have been seeing in the last years. And we could see, for example, regarding hospitalization. We always can organize hospitalization into three major, at least three major measures that we put in place in the last few years. Normative measures, to say, and what Alejandro was saying that guidelines to hospitalize. And we have seen that the guidelines are continuously to be more and more strict to hospitalize. So we try to avoid hospitalization like that. We also have preventive measures, or what I was talking about, ambulatory care sensitive conditions, and the providing care, for example, or controlling hypertensive patients in primary care or diabetes in primary care. We know that we will avoid those hospitalizations. And then we have alternative services. What I believe is that these alternative measures, for example, we have developed, for example, one-day surgery. Nowadays, in Portugal, 65% to 70% of all surgeries are made or performed in one-day surgery. This allows us to double the number of surgeries that we do in the system. There were barriers for it, of course. We need to change the way that surgeons did those surgeries. We need to convince the population that to be hospitalized in the same day and be discharged in that day, it was something good. We need also to do the investments to new operating rooms, but we did this in 10 years. 80%, more than 80% of all the procedures that can be done in one-day surgery, they are being done. Of course, we are not talking about transplants or more complex surgeries, but even now we are discussing hip replacements to be performed in one-day surgery. And we have examples of hip replacement that is a complex surgery done in one-day surgery. What we are now discussing, and I believe the Internal Medicine Federation, European Federation, what they are discussing now, for example, is the developing of major ambulatory services for clinical patients, not surgical patients, for medical patients. What we are talking about is developing of home services, and we have several in Spain, for example. The home hospitalization program is very, very well developed. I believe in Portugal, we are in the first stages of it. But I really believe that day hospitals, home, this idea of hospital at home will grow a lot, and technology and innovation will help us on this. And at some point, we will see that we can continue to reduce at least the amount of care that we provide for inpatients.
Yes. So yes, Alexandre. So clearly there is a lot of room there for innovation, and actually this is the scope and purpose of your talk here with the students, because it's really, really important. And you deliver the message. They will change the system. So it's the new generations for sure that will change the system. So I would like to challenge you to raise questions. So Inês, you want to raise a question? Yes.
Hi, good morning, Alexandre. So I would like to know, since you are an healthcare manager, what is your opinion about doing an MBA? Do you believe it will help us if we want to change our career to the healthcare management?
You are asking the right person. You are asking the right person. Please, Alexandre.
No, that's another field that I work. That is the competencies of healthcare managers, and something that I'm quite keen on. What I believe is, first of all, everyone can have their own path and develop their own path. What I believe is that actually what you need to and there isn't a receipt for it. Okay, what I believe is that for being a good healthcare manager, you need to at least to have knowledge from both sides, from what we could call public health and business management that you can acquire from an MBA. But please do not disconsider the need to have a very good knowledge in public health. Actually, I believe that one of the issues that we face today, and this is mostly after the 80s, is this idea that, of course, this is a business, an industry, that's for sure, and you need to have business skills. But to change the way that we provide care and to improve the way that we provide care, we need always to have a population-based approach. And this is applied for medical doctors, even for nurses, for managers, for economists. We need to have very good skills and knowledge and concepts on the population health, what we could call public health.
Alexandre, but let me just, well, it's not provoke you, but challenge you, because I understand, obviously your response was very clear to Inês, but I think there are elements there, even from your own profile, that can be inspiring to these students. And as far as I know, your graduation was in biology, so you could just tell them how you went from biology to hospital management.
I believe that we will have 1 hour more, so I will discuss it.
No, the short version, please.
No, the short version is that I don't. It depends on the profile of the person, but in my profile, I really believe that research will not make me happy. So I needed to have something that has some. I don't know, influence in society, to try to influence the way that things are there. And this commitment of public services, and I'm a civil servant, so this is something that grows with you or not. So, and in that sense, I believe that producing papers and being in a lab, even though for me, I loved it, but it didn't accomplish my my professional needs and personal needs. So I evolved from that, from that to acquire more competencies in management, and I have done this career for the last 20 years. But always, and even though I have this career with at least 15 to 20 years at this point, I don't stop to try to acquire more knowledge. And that's why I'm in a PhD program, as I don't know, some of you are also probably. So that's why we always need to continue to acquire more knowledge. And what I believe is that even for being a good healthcare manager, it's not only to have competencies in business and in public health. You really need to know that we always need to know that the system is dynamic, and you need to also to continue to collect data, to analyze data, and to take decisions. And in that sense, and I think that's a big when people that work in policy making and have responsibilities, that is something that is quite relevant, is to know that you need always to take into account the data that is there to make decisions. And from that sense, I believe that I learned a lot. Another issue that's, let me just, João, just say this. I don't know, what are the degrees that you are from, most of you?
Well, most are from biomedicine areas, so biology, biochemistry.
So by biomedicine, I believe that is quite
biology,
relevant.
but also medical doctors, psychologists. So it's a diverse group.
But the idea is that, and I believe that from most of your trainings or education, that is something that is quite relevant in healthcare. That is to know that there is a life cycle. And most of our, at least my early studies, were about life cycles. Something that is born, something that has a life and dies. In that sense, healthcare is of course for persons, but this sense that is their life cycle that we need to take care of, and not only to take take care of acute events, and we need to take care of something that has a life. And life is not a second, and just to transform it to what I was saying, is not an hospitalization, is not a medical appointment. Life is a life cycle, is something complex that we need to respect. For being a good healthcare manager, I believe that you really need to know that.
Thank you, Alexandre. So there are more questions from our students. We are, yes, Tiago and Teresa, I see. And so I believe that then we take these two questions as last questions, unless there is some very pressing question from your side. So Tiago, please.
Dr. Alexandre, thank you for the presentation. In your opinion, which place do you think that there is the best models of healthcare? Can you say some example?
Regarding countries?
Yes.
You can have several books on it. So saying what is the best, even though I don't buy them, I must say, but because I don't believe, no, because they aren't excellent. That is something that you can sell. That is this is the best health system in the world. Actually, what there is a study from the beginning of the century, 2000, that is a World Health Report from the World Health Organization. Annually, we have the World Health Report that is about health system assessment. That report was published once. Do you know why? It was a clear assessment of the health systems in the world. Mostly because the biggest donor of the World Health, it's something also related to what we are facing now with the United States and the World Health Organization. Is back then the US. Lots of controversy, of course, but the biggest donor of when we are saying that this is the best, this is the second, third. Actually, back then, the biggest donor of WHO was against it, and it was placed very badly on that hierarchy. What I believe is that independently in the way that we assess the health systems, what we need to know is what we want to achieve. And what we want to achieve is universal health coverage. That is the tool to achieve better health outcomes. Not only to know that we are increasing our life expectancy, but most of it is that the health expectancy or these health outcomes that we are achieving, they are equally distributed on the population. I work with several low and middle income countries in Europe and Africa, and even in Southeast Asia and Central Asia, and all those even low-income countries and middle-income countries, they are increasing the life expectancy, for example. But still, in those countries, they continue to face these huge inequalities. What I believe, Thiago, you are from Brazil. No, I see from the accents.
Yes.
Yeah.
But can you give one?
I will give you an example from Brazil.
No.
We have probably the two best hospitals in South America that are compared with the best hospitals in Europe. Albert Einstein and Sírio-Libanês in São Paulo. Even good examples in innovation, at least Albert Einstein. Very, very good incubator inside the system. But they are 4-5% of the population, Brazilian population.
I know, Professor, but I'm curious to know, in your opinion, an example of good healthcare system, a place with excellent healthcare system where everything works.
What you want to live there?
No, I want to copy. I want to learn and copy. What?
No, you can see. I believe that the countries that are more or at least dealing with these issues about aging and the way that we need to change the way that we provide care. And first of all, the country that is more flexible in Europe probably are the Netherlands. Okay, I don't recommend the system for several reasons, but regarding innovation and flexibility, for example, when you have an health insurance that is paying for a group of nurses to increase literacy in the community, you don't see that elsewhere. The Birdswalk system, you can see it on the online. You can Google it, and you see that is a system that was developed by a group of nurses that go quarter to quarter to teach the population how to or to increase their literacy, how to deal with aging, with isolation, and it's an health insurance that is paying for it. Okay.
Alexandre,
You can see this.
Let me just say a word because we are running really out of time. So if
but also
let me just summarize to Tiago, and then we pass to Teresa, please.
Yeah, just not to go continue there. There are some examples of integration of social services and healthcare. For example, Scotland can be a good example. Also Northern Ireland also. So there are several examples that you can follow. I believe the home services, Nordic countries are very, very interesting. For example, Finland is very interesting in the home services, for example, dealing with dementia and all that. So there are good examples there. I don't believe there are widespread examples in the country.
So thank you. Teresa, please.
So good morning. Hello. Thank you so much for the talk, first of all. I have only a small question. So regarding the innovation barriers, in your opinion, what would be the barrier if we had the chance to remove it that would have the most immediate effect? So concerning the fragmentation of care, the lack of a retail market, the regulatory barriers, and the reassessment.
I will answer you a different way. What I believe is that at the level of health systems, for example, in the National Health Service in Portugal, what I believe is that we need to create structures that put in place measures that reduce those barriers. What I believe is that you need to have a strategy for innovation. And in that sense, you need to, now we have an agency for biomedical research, ICIB, but what I believe, we don't have a real strategy to reduce those barriers. And in that sense, we need really an agency and a strategy, not only, for example, for big data or even personalized medicine. We really need, or precision medicine, what we really need is a strategy where, for example, we create structures in hospitals, healthcare centers that create those fast tracks for innovators.
Okay, so reducing all of them at once.
And if you go, yeah, they are equally relevant. But if you create those fast tracks, you need to test products, then to create the massification to sell it and to create a sellable product. In that sense, if you create a strategy to test products within the National Health Service, reducing the barriers between primary care and social services and hospitals, in that sense, you create a flow and you will test technology. And I believe in some senses, some countries are doing it very, very interestingly, creating those kind of opportunities for startups.
Thank you. Thank you so much, Alexandre. So I really say many thanks for your talk and really interesting discussion. So I believe we would keep some more time here discussing, because there are many not actually other questions that could be raised. But we close now the session. Actually, I'm going to just close the YouTube transmission.